All right. All righty. So chapter 28 is the last chapter that we haven't covered this quarter. This is the endocrine system. I think this is probably one of the driest chapters, and maybe that's just my personal kind of like feelings on the endocrine system, the hormone regulations and everything that goes into it. It's really like a methodical system. And it's different than the adult system with endocrine, just like most other chapters we've talked about, but they have a huge important part of the endocrine system with our pediatric patients is related to growth and development. It goes back to their growth and development of being able to grow and develop and go through puberty and make all of those changes that happen for kids. You know, we see hypothyroidism and hyperthyroidism in peds patients just like you can in an adult, but there's other systems that are impacted more significantly with peds patients with the endocrine system. I only touch on the kind of most frequently seen endocrine system dysfunctions. There are tons of other things in the endocrine system that can go wrong with patients. If you're working in pediatrics, you'll see, like, especially at a major facility like, you know, Children's here, I worked at Stanford Children's, like those like big hospital systems. Patients come from all over the world sometimes to be seen by endocrine specialists in the United States for disorders that are like 1 in a million. So you may see those kinds of things if you're working in peds. But these are the most common. Diabetes kind of is the most significant one that we're going to talk about today, but we're going to talk about a couple other things. Yeah, Ashley, endocrine is dry. And as many years as I've taught this chapter, I try my hardest. It is just not an exciting chapter. There's not like, there's not an emergency that like patients come in and like big emergencies that happen in the endocrine system. I don't know. We're going to talk about the most important things you need to know about this chapter. And some like interesting disorders, I think, but just it is more dry. All right. Again, the pituitary gland, the thyroid gland, your adrenal gland, your pancreas are the major organs that we're thinking about when we're talking about these systems. We're going to talk about basically high and low levels of the most common things. And remember, your endocrine system is 6 organs that work together to make all of this happen. And there's like a really minute system in place that our bodies do make that happen. If the hypothalamus isn't working correctly, it's not controlling the pituitary gland correctly, and that may not control the other glands correctly. So they all have to work together to regulate growth and development with our pediatric patients. So the pituitary gland is considered kind of the master gland. Don't forget, though, that it's controlled by the hypothalamus. So if we have dysfunction of the pituitary gland for any reason, it could be a patient that has problems in the hypothalamic region. That could be something in a pediatric patient that's like a tumor in that region, or sometimes we see dysgenesis where it didn't develop correctly while the patient was growing in utero. Or that could be going on in the pituitary gland itself as well if we're having dysfunction. There's 2 lobes to the pituitary gland. Think back to patho on this one. There are quite a few hormones that are secreted by them, but let's talk about kind of the major ones that we're going to review here today. The posterior lobe only has 2 major hormones that I want you to remember. What are they? Posterior lobe, 2 major hormones. What are they? One of them goes back to OB. Just talked about it in OB. The other one has to do with P, if that helps. Yep, oxytocin is one, and ADH. Good. Oxytocin, antidiuretic hormone. Those are the 2 at the posterior lobe. Your anterior lobe has many more hormones related to it, but there are basically 5 major ones that I want you to remember with this one. So does anybody remember the major hormones from the anterior lobe? Growth hormone, absolutely. ACTH, adrenal cortical, luteinizing hormone, yep, LH. Okay. TSH, thyroid stimulating hormone, yep. There's one more. Yes, FSH, follicular stimulating hormone. Good. Okay, those are the 5 main ones that are from the anterior lobe. There's other like subset hormones as well, but those are the major ones that are controlling other glands, and really kind of the important ones that we talk about with growth and development with PEDS patients. So pituitary function controls many of the other systems that we're going to talk about. So specifically related to the pituitary gland, hypopituitarism, if we have low pituitary function, a major one here is growth hormone deficiency. So growth hormone deficiency. All of our somatic cells in our body have to have growth hormone to grow. And during those pediatric ranges, depending on how old the patient is, that's when they're growing most rapidly. And it depends on the developmental stage that they're in on how much growth that looks like. So for example, for the toddler, they're growing about 3 inches a year in those toddler years. The school age child is only growing 1 to 2 inches a year. So it slows down as we get older. 75% of our overall growth, about 75–80% of our overall growth happens before adolescence. In those, about 10 to 12 years of time. And then during puberty, during that 1 to 2 years of puberty, we get about 25% of our overall growth at that point. So for this one, for kiddos, the primary site for dysfunction for this disorder, growth hormone deficiency, is usually the hypothalamus. And that could be a tumor. That's the most common reason that we see with this one. It can also be a tumor in the pituitary gland itself as well. So it's a tumor in either area. That's kind of the most common reason that we see this. It can be trauma. It can be, there's congenital abnormalities that can cause this as well. Either way, the patient's going to have low growth hormone, and that's going to cause slow growth. Usually these are kids that grow normally in that first year of life, and then they slow down their growth. They're less than that 3rd percentile on that growth curve. So that nice growth curve that we talked about at the beginning of the quarter, they're less than 3rd percentile. And the picture that I've got on the slide here, there's a group of 8-year-old girls. All 4 of these girls are 8 years in age. The tall 3 have normal growth. This child here with the pink undies on, she is developmentally an 8-year-old cognitively, but physically she's about the size of a 3-year-old. And so that's what we typically see for kids that haven't been addressed. This issue hasn't been addressed, and they're growing at a very, very slow rate. Now, this disorder doesn't usually cause any cognitive deficiencies. So these kids will have a normal cognitive level for an 8-year-old. Sometimes they're a little bit behind, but for the most part, cognitively 8, but physically they look younger than their stated age. They do have sometimes extra weight gain because they're not gaining that height upward. They're usually eating the same amount that their peers are eating. So it's not uncommon to also see some obesity associated with this because of that slow growth that kids are having. Related back to growth of the kids, Dr. Tanner is a major researcher, was a major researcher. He died a couple of years ago in child growth. So I know we talked about this a little bit in the class yesterday. Tanner stages of sexual development. He was the one that wrote really kind of and researched how kids grow and move through puberty. So these are a couple quotes from him. Growth is the single most important indication of health in a child, which is absolutely true. And it's one of the reasons why we have such strict protocols that we follow of like measuring annual growth in our pediatric patients and plotting it on those growth curves. Look to make sure that they're meeting those average ranges. It indicates things like nutritional deficiencies. It can indicate something like a cognitive deficiency. It can indicate something like heart issues with patients. So growth is really something that relates back to a lot of other health issues that we're looking at in kids. If they're having challenges with growth, what else is causing those issues? They also said that the heights measured in the averagely casual clinic are useless, even for clinical purposes, let alone research. it contradicts it, right? If it's the most important thing that we look at, why are those measurements useless? The main reason I put this up here is because I want you to remember what we talked about at the beginning of class is those measurement systems that we had in place. The recumbent length board, that laying down length until they're 2 years of age, is important to get accurate measurements. And then once they're older than 2, getting that standing up measurement, making sure they're flat on their feet, they don't have shoes on, and being consistent with that, not doing things like laying them on the sheet and drawing lines and measuring them that way. It's just not the most accurate way to do it. And for kids, especially that are having growth failure, a kid less than 3rd percentile, or that failure to thrive that we've talked about, it's really important to make sure that those measurements are accurate. It just throws everything off if something is out of whack for that. So making sure your measurements are accurate, as well as don't forget that our ethnic backgrounds or genetic backgrounds play into growth for kids as well. We don't want to just look at the percentages without looking at that bigger picture for our patient. Looking at the parents, you know, I think I mentioned at the beginning of class, like, you know, if I'm looking at the parents and the parents have giant heads and my patient has a giant head, it's probably genetics. If the parents are short in stature, their child is probably going to be short in stature. If their child is very short and the parents are tall, what is causing that? That would be something to keep in mind, like those differences in that family history. And when we're assessing kids that have growth hormone deficiency, and they have failure to thrive, they're less than that 5th percentile. And for these kids, they're usually less than 3rd percentile. Look at that child's history, look at that parent's history, and look at the family growth patterns, right? Is this something that runs in the family? Only 5% of kids that have growth failure, only 5% have growth hormone deficiency. So it's a really small percentage of kids that have failure to grow that have actually deficiency of the growth hormone. And I'm going to use my daughter as an example for this because you've seen pictures of her throughout the class. She was born at 4 pounds, 12 ounces, full term, which is extremely small for a full term infant. She was negative percentile when she was born, and she is about 3rd percentile right now. And she's been less than that 3rd percentile for most of her life, pretty much her whole life. So when she was 3, so 3 is when we do this initial assessment, usually for these kids. We're seeing them like fail to grow those first couple of years. And by 3, we want to make sure that we're doing this early assessment. We cannot wait until they're adolescent because by that point, again, they've gained, or they should have gained most of their growth by that point. So we have to do this on little kids. The 3 is when she had this assessment done, and that's when we typically do this. We test lab levels. So we look for the lab levels. Definitive diagnosis is based on the absence or low levels of pituitary growth hormone. So literally just testing lab levels is kind of the main thing that we're looking at for kids that have growth hormone deficiency. But we want to make sure that we're assessing that family history. And for my daughter, I'm 5'7", my husband's 6'1". We're average height for our ethnic backgrounds. My sister's almost 6 feet. Like there's no shorter stature on my side of the family. So there's nothing to explain necessarily per se that why she's shorter in stature and smaller in size. My husband's mom has anecdotally said that he was small for his age until about school age. Small for his age. We have no data to go base it on. So it's just, that was what we were looking at. We had her assessed. Growth hormone levels for her were normal, so there weren't any deficiencies with growth hormone. The other thing that we also assess is a skeletal survey for kids. We're looking for growth failure. I mentioned this one a couple weeks ago, doing skeletal surveys on kids, that we can age the skeleton, and we're looking for differences between their skeletal spine, skeletal survey, and their chronological age. For a 3-year-old, middle hand here is what we should see. And what we're looking at are these little ossification plates in the wrist. So those little tiny wrist plates, those little tiny bones that you have in your wrist here. Remember that I mentioned that babies, when you're doing an IV on them, you can literally like bend their hand to their forearm because they're squishy. They're just squishy. They'll bend in half. They don't have bones there like we have. They don't have those strong ligaments, those strong muscles there. We're looking at all these little tiny plates here. You could see with a 1-year-old, they're like barely there. And by the time they're 5, they've got really good development of that structure in that wrist. This is what a 3-year-old should look like, is this middle one. Female is the bottom, male is the top, and a little bit different size-wise. And for kids that have growth hormone deficiency, they're going to have a skeletal survey that is younger than their stated age. So the 3-year-old, their skeletal survey usually looks closer to a 2-year-old. So they have less growth in those little ossification plates. It's the combination of that, though, to get diagnosed with growth hormone deficiency. It's really having those low levels of growth hormone that gives them the diagnosis of growth hormone deficiency. For my daughter, she only had the skeletal survey that was positive. Her skeletal survey was a 2-year-old, even though she was 3, but she did not have low levels of pituitary growth hormone, so was not diagnosed with growth hormone deficiency. For kids that are diagnosed with growth hormone deficiency and they need treatment for this disorder, we give them growth hormone. We literally just give them growth hormone. It's biosynthetic growth hormone that we give at bedtime. Anybody remember why it's important to give it at bedtime? It doesn't necessarily cause sleepiness. It's not like a side effect of it. Yes, kids grow at night. So remember that growth hormone normally is secreted at night for anybody. Growth hormone is secreted at night. That's why there was a test question about what predisposes adolescents for the need for sleep. It's that growth, that rapid growth cycle that's happening, and that growth hormone that's increasing, that they need to sleep more during that time period. So we give it at night to mimic those normal biorhythms. That's a great question, Ashley. So with my daughter, yeah, we think it maybe is genetic based. It may have been something she was diagnosed with in IUGR, in utero growth restriction of some sort, and they don't know exactly why. So she's just probably always going to be like that. Yeah, yep. There was no other diagnosis for her. So we'll see. Maybe that's like small for his age with my husband's history, is maybe she'll hit puberty and she'll like shoot up in height, but yeah, so she's not getting growth hormone because it's not a deficiency for her. So for these kids that need this growth hormone, we give it at night. It's a sub-Q injection that they get. It's kind of like an insulin injection. If it's related to the tumor being one of the more primary causes, then surgery would be done to remove the tumor. Sometimes that does cause dysfunction with other problems. They may also need hormone replacement of other hormones. So that could be things like TSH or cortisol, because ACTH isn't being secreted. So those other hormones are going to have to be monitored and checked. Things to keep in mind, your nursing things to keep in mind with this one. Identify them early as possible for that growth, right? If we wait till adolescence, it's too late by that point. Even by school age, that 8-year-old in that picture that I showed you, there's already several years of growth that's already been lost. And once they hit that puberty growth spurt, the bones fuse, and that's it. That's as much growth as going to happen for the patient. So identifying it early is important for patients. Family support kind of goes along with the last bullet point there, which is treatment is expensive. This one's about $50,000 a year for treatment because these are daily injections that have to be given. So there's a lot of expense associated with that. Not every insurance agency covers it very well. There are some companies, where patients have their 20% copay, and 20% of $50,000 is still a lot of money for families. So that can be a pretty big problem to kind of overcome for families. It's not something the child has to have, but it's something that is needed. So getting it covered, switching insurances sometimes, or just like sometimes we have to fight with the insurance agencies to get it covered. There are some that are really great about it. Kaiser, for example, has 100% coverage for this. There's no copay. Kids will get their injections and not have any issues. They get seen regularly for it. So there are some companies that do a better job with this than others. Also think about the body image. You have a child that is cognitively an 8-year-old but looks like a 3-year-old. It's very easy for others around them, peers and adults, to treat them how they look. Most of us, when we're interacting with kids, kind of make an assumption about how old they are. And so it can be something that they have to deal with that, as well as that being different from their peers is something that they have to deal with. So making sure that we think about their body image and psychological support is something that we would want to make sure we're covering. And then how do we prepare this kid for their daily injection? So think about the 3-year-old that I mentioned is the typical age that we're diagnosing this. How would you help prepare a 3-year-old for daily injection? What kinds of things can they be involved in? How would you teach them about their injections? These are so cute. Shown on adult, and that's why I have the picture here of Daniel Tiger. This is a show that preschoolers like, pretending on the little dolly first, and literally just like, you know, bringing a regular syringe in that they can hold and play with and pretend. What else? Yes, put a Band-Aid on it. It makes everything better. I have an example of something that happened yesterday. I went to pick up my daughter from after school care, and there was a little kindergartner, one of the little kindergartners in there. So the preschool age, they're about 5. And he was getting Band-Aids put on. And the lady that runs the program was like, oh yeah, he fell and, you know, he bumped his finger and he had like a little scrape on one finger, but he wanted Band-Aids on every finger because he'd hit his whole hand. He's like, need the Band-Aids, and she had to put a Band-Aid on every single finger. So that is a perfect example of something that those preschoolers do at that age. Band-Aids make everything better. Let them pick out the Band-Aid. That helps with that participation. It gives them a choice. You want the blue or the pink or whatever, you know, let them go pick out a box of Band-Aids at the store that it's something that they like, whatever it is. What else? Let them play with the syringe without the needle. No scary objects. Reward systems are great, especially for this one, you know, because this is a daily thing. You know, at the end of the week, man, you held still, you helped participate, you get an extra reward this week. Sticker chart, those kinds of things are helpful. Yep, stickers. Yep, kids love stickers. Most kids do. My kid doesn't like stickers. No. My kid still has that great like RBF face. What kind of things can the 3-year-old participate in giving the injection? They're not going to be giving it themselves, but what could be something that they could participate in with the administration of the injection? Yep, they can clean the site with the alcohol pad. It doesn't have to be a super like scrub. They just have to like rub it a few times on there. Okay. And yeah, they can count to 3. That's a good one. Yep, using the treat afterwards. Yep. And which side? Yeah, point to where it goes. So exactly. Q injection, right? Do you want it on the left side, the right side, the arm, the leg? Give them the choice. Remember, those choices that are great at that developmental age is really important. It helps support their developmental stage. For your preschoolers, they're in the wow, totally blanking. Initiative versus guilt phase at this age. So they want to initiate that learning. They like to be part of that process. So giving them those little things. And then as they get older, giving them more leeway. So by the time they're school age, they can participate in those cares and they can probably give their injections themselves by the time they're hitting school age. All right, that was low function. Now when we have pituitary hyperfunction, we can get gigantism, which is excessive growth hormone before those epiphyseal plates close. And that's the end of puberty. So that's 17 to 18 for girls. That's around 20 for guys. If you think about what happens typically in high school for boys, the height usually comes kind of by the end of high school, but in college, guys have a tendency to get a little bit broader in the chest. It's because those bones are still growing. Like the clavicle bone is one of the last bones that fuses. So it's still growing even into like 2021 for men. So this is kind of a pediatric disorder. It's kind of an adult, like early young adult disorder. But it's excessive growth hormone before those epiphyseal plates fuse, which causes excessive height. In general, in the United States, we actually don't see this too frequently with the excessive height anymore, just because we have such good medical access and access to care. when we do those normal assessments, looking at height and growth for kids, that we usually catch this before it gets to those excessive heights, because we're going to do things to suppress that growth hormone. Are downsides to the excessive growth, and as well the muscle development that goes along with that. So patients that have gigantism also have an equal height to weight ratio. So they're just bigger all around, and that causes a lot of other complications on other systems in the body. The heart specifically is one that's really impacted because it has to pump harder for that massive body. Joints are another one that's really impacted. So joint abnormalities and arthritis and pain, especially as patients get older, complications that happen for patients that have gigantism. With PEDS patients, one of the earlier signs that we may see for early gigantism, excessive growth hormone, maybe those fontanelles that don't close at the appropriate age. So that anterior, which should be that 12 to 18 months, it doesn't close by that point. You know, that 18-month range, when you're assessing it, it's still open. Diagnosis is based on history, looking at their growth again for this one, looking at family history. Tumor is one of the more common reasons that we also see being caused by this, either in the hypothalamic or the pituitary region. If it's related to a tumor, we take out the tumor. That may lead to hyposecretion, which we would then end up having to replace any hormones that may be needed for that one. Sometimes if it's not related to a tumor, but we want to slow that growth down, we will do a radiation to the pituitary gland, which can cause decrease in those hormones and slow that growth down. I have a picture of Andre the Giant up here. He ended up dying from heart failure, again, because of that, like, it's because of his massive size. And he had a lot of joint complications over the course of his career. If you're a Princess Bride fan, there's a lot of like scenes in there where they're kind of in the mountainside and that kind of things. He had to have an ATV to get around for filming because he had so many problems walking because of his joints that he had trouble getting around for movie filming. So we try to avoid that. We also can see hyperfunction after those epiphyseal plates fuse, and this one's called acromegaly. This one's technically not a pediatric disorder, but it's sometimes it's covered in your PEDS book. It's also sometimes covered on the HASI, just in terms of thinking about that excessive growth hormone. So this one is not the height that we typically see or the growth that we see from bones. This is more like face and hands, skin and hair are areas that will still continue to grow after we finish puberty. But those are areas that are impacted by this growth hormone after those epiphyseal plates fuse. Again, this is another pretty rare disorder in the United States, just because we do usually catch this earlier on nowadays. These are old pictures for that reason. This is what it looks like for young adults, is normal development at the end of puberty. As that growth hormone becomes more and more and more as they get older, it's the face and the hands that we typically see those changes to their facial appearances. But again, we don't see this in the US too often. We treat it if we do. Same treatment for acromegaly like you would see with gigantism. Precocious puberty is early onset puberty. So remember, like late puberty, latest is usually 13 to 14 for girls versus boys. So girls hit it a little bit earlier than boys do. For early onset, for boys, it's 9. For girls, it's 6 for our African American or our Black population. It's 7 for more of the Caucasian population. Just kind of in general for ethnic backgrounds, darker skin tones in terms of what we see. So our Black population has a tendency to hit puberty earlier than Caucasians, and Hispanics are kind of in between in terms of like age of puberty for girls at least. So that's why it's a little bit earlier on for our African American or Black population in the United States. This is really early for puberty for girls, and it does occur more commonly in girls than it does with boys. The main type that we see with this is central precocious puberty. I think central region, it's coming from the brain, it's coming from that central location. This, the hypothalamus or the pituitary gland is secreting that FSH, that luteinizing hormone, too early, and it's stimulating those gonads to start with the process of hormone regulation with their androgens and estrogens. That's the most common type that we see. There is also a form called peripheral precocious puberty, and that's usually coming from the gonads themselves, the ovaries and the testes. That one also is linked more rarely with child abuse, specifically sexual child abuse. That can trigger that early onset sometimes. And then we do see incomplete precocious puberty as well, where kids go into early onset puberty, but then it stops, or it like starts and stops and doesn't like continue fully, but it'll stop a little bit. So that is also something that happens. Treatment is going to depend on the cause. Things like tumors or problems with the hormones. If we can find something specific, that's how we're going to treat it. If it's just because those hormones are getting released too early, we treat with a medication called Lupron, luteinizing hormone releasing hormone. It basically slows down the growth for our pediatric patients for puberty. It doesn't stop it completely in most cases, but it slows it down. So they'll get these injections throughout that early onset, and then when they hit the normal kind of like 10 to 12-year-old range, we'll stop those injections and just let the rest of puberty kind of take over from there. So it's discontinued at like earlier puberty age ranges. Psych support is needed for this one, just like it is for the kids that are having growth failure. This is a child that's going to be growing early, so they're going to have height that is going to be ahead of their peers. They're going to be taller than their classmates. If you think back to middle school, like end of elementary school, middle school, you remember the first girl in class that got boobs? She was probably picked on. That's really common, right? The differences, like kids pick on those differences. Kids are really mean to each other. So the kids that have this have a really hard time with that because they look like adolescents and they're not even close psychologically, cognitively to that point yet. So making sure that we have support for the child and the family on that side of things is also important for early onset puberty. And then diabetes insipidus, remember this one is not the same as diabetes mellitus. This one's that posterior lobe of the pituitary gland with ADH, antidiuretic hormone. If they're not antidiuretic, they're diuresing, they're peeing, they're urinating, uncontrolled diuresis without that regulation in concerns to like fluid and electrolyte balance. There's a family link with this one. So if there's a positive family history, there's an increased risk of the child having it, but most cases are idiopathic. We don't know what that's linked to for DI. First sign, enuresis. That's that symptom that we talked about back in like week 2, where they're urinating, they're wetting the bed, they're peeing the pants. So that may be one of those early signs of this for kids with either form of diabetes, but this specifically because they're just like peeing all the time. Maybe a primary symptom. Then think about diagnosis for this one. We do an oral fluid restriction test. We stop their NPO, we stop their fluid intake, and then we measure urine volume. Is the urine volume going to be high or low? High. So what we would see is that urine volume is going to continue to be high. They're just going to keep peeing, and then they're going to end up becoming dehydrated because they're going to lose all their fluids. Polyuria, polydipsia, that enuresis symptom, maybe those early warning signs. Now, kind of an interesting thing about infants specifically, not under 4 months of age, infants that are older than 4 months, their irritability and their fussiness from being like thirsty and dehydrated is relieved by water, but not by milk. So like those normal milk feeds won't help them, but you give them a bottle of water, they'll feel better. It's kind of like an interesting thing that goes along with this one. And they're going to be more likely to become dehydrated. Remember, their kidneys are already not functioning well. So this disorder causes some more significant complications with their fluid and electrolyte balance. The treatment and management for this one. It's a fairly easy disorder to manage in terms of replacing the vasopressin or the ADH. Education is important for this one. Parents hear diabetes and they automatically think diabetes mellitus. Like it's just the most common diabetes that we see. So they hear that and they think blood sugars. Nothing to do with blood sugars, right? Completely different disorder. So making sure that we educate and replace the vasopressin that they're missing. This is going to depend on the size, the age, of the patient and symptomatic management. So that 1 to 2 milliliters per kilo per hour for urine output for kids is what our goal is. We're looking at their urine output. aiming for those normal urine outputs for our patient. So giving enough vasopressin to manage that. With littler kids, parents have to be more vigilant about how many times have they gone to the bathroom, how many wet diapers have I changed today, so that they can monitor that and adjust dosing. The time kids with this get to be adolescents, they are more aware of the signs and symptoms. They can manage it more themselves, but they can sometimes, if they're really paying attention to it and they're good at it, for the kids that are, they can make those connections to, oh wait, I've gone to the bathroom like 5 or 6 times in the last couple hours. That's not normal. I probably need more dosing. And they can kind of self-adjust that dosing up and down depending on what they need for the day and activity levels and those kind of things. Intranasal is the more used form of this nowadays. Any of these forms are fine. They all work well. Intranasal can be adjusted a little bit more easily because it's fast acting. It's absorbed through those little tiny capillaries in your nose. And it's easier to like adjust it up and down with the intranasal route. IM and sub-Q injections are fine though for younger kids especially. If they are unresponsive to vasopressin, it doesn't work. We give them the vasopressin and their symptoms are still occurring. They may have the rare form of diabetes insipidus that's coming from the kidneys themselves. It usually means that the body's secreting enough ADH, but the kidneys aren't responding to that vasopressin. And that one's actually a really hard disorder to diagnose. Sometimes they end up needing kidney transplants because of it. It's a very rare disorder. Overall, I don't even remember what the incident of it, but it's like 1 in 100,000 or something like that for that one. All right, so finished talking about the pituitary gland. Now we're going to talk about the thyroid gland, which is also controlled by the pituitary gland, right? Remember, we have that TSH that's secreted by your anterior pituitary lobe. So the thyroid function, it could dysfunction with the hypothalamus or the pituitary gland or the thyroid. Hypo and hyperthyroidism is seen with kids. A big thing to think about with just general picture with thyroid function, growth with pediatric patients, specifically related to metabolism, their basic metabolic rate, their metabolism, whether it's high or low, also impacts cognitive development. So their level of IQ, their cognitive development is something that's impacted by thyroid function. It's different than an adult that has hypothyroid, right? Our brain is already developed at that point. We can have like brain fog and sleepiness and those kind of things, but kids, we can stunt their IQ growth, their brain growth. So with that, thinking about that, there is a form of congenital hypothyroidism where kids are born with this. They're born with low levels. Primary reason for this is thyroid, coming from the thyroid. Secondary would be coming from the pituitary gland. So pituitary tumor or something along those lines can cause it. Main thing that we see that causes this one for congenital hypothyroidism is thyroid dysgenesis, which is a thyroid gland that didn't grow well when baby was developing in utero. So it just didn't grow. And that causes the problems with their decreased hormone levels. The problem with this disorder, again, is that if it's not caught in those early months, literally within the first about 3 months of life, we cause IQ loss. Like they will already have a decrease in their IQ abilities if we don't catch it within those first 3 months of life. So for babies that are higher risk, which would be patients that have Down syndrome, they're a much higher risk of having this. We do automatic screenings for them. Otherwise, a baby that doesn't have any other like major signs and symptoms may not get caught right away. And the challenge with this is that a lot of times parents that have babies that have this congenital hypothyroidism say that they have like really good babies. Their babies sleep more. Their babies aren't as fussy. They eat and they sleep. And that generally leads parents to think that like, oh, I must have this like great baby because they're not fussy. They just like eat and sleep. Not a good sign when they're sleeping too much. We still need those periods where they're awake and alert during the day. But catching that sometimes is hard because parents don't always recognize that as a problem when their baby's like just eating and sleeping. Constipation is also something that's common with these babies. So juvenile hypothyroidism, older kids that get this, it could be because they had congenital, they're born with it. Most commonly, it's acquired in our pediatric patients. And the most common form of acquired hypothyroidism in peds patients is hashimotos, which is an autoimmune inflammatory response. Now, worldwide, the most common cause is dietary iodine insufficiency. So across the globe, that's the most common cause, but in the United States, because we use iodized salt in pretty much everything, like all of our processed foods has iodized salt in it, we don't see that as a problem in the US. There are some other reasons that we sometimes see this: if they had to have the thyroid taken out, if they had cancer, or they had an infection or trauma to that area. Those are other reasons why a patient may have hypothyroidism. Low levels of thyroid. Like everything in the metabolism is slowed down. So decreased growth, that normal growth curve is going to be slow. They have skin changes, or they get dry, sparse hair. Periorbital edema is the eye changes that happen with this patient. Constipation, sleepiness, mental decline. Older kids, what does that look like? Infant is just the kid that's sleeping more and eating, eating and sleeping and eating and sleeping. But in a school age kid, what might that be like? What might be some assessments that would be something you would think about? If it could be decreased play, if they're just getting sleepier, they don't want to run around on the playground. Yep. One more kind of important thing too. Yeah, school. Yep. School engagement is really important with them. So they may not be performing well in school. Like it could be the kid that was doing really well and they like excelled at things, and then all of a sudden now they're just like having a hard time with school and thinking through math problems and just participating. So school is a big one for kids that we see changes in those with the sleepiness and other things that are going on with them. So low levels with this one. Goiters can happen with kids that have hypothyroidism. It does happen with hyperthyroidism as well. So this is both. Basically, this is an enlarged gland. A congenital cause of a goiter could be maternal ingestion of antithyroid drugs. So if mom has hyperthyroidism and mom has to take her antithyroid drugs, baby is getting exposed to those hormones. Baby's going to be born with a goiter. Think about airway compromise with that, right? If you have a goiter, which is what's in this picture right here, that airway, especially for infants that have tiny, tiny airways, that airway is a priority with that patient. Other reasons, again, could be cancer, it could be inflammatory conditions, it could be the dietary deficiency. It's much more rare in kids, also much more rare in the United States. In Cambodia, working in Cambodia, we have really high rates of goiters in patients in Cambodia because only about 3% of the population there has access to iodized salt. Only if they're living in like the major city, they have access to iodized salt. Most of what else is found in the country is non-iodized salt. So goiters are really common, especially in women. And on a trip, a GHP trip there back in 2019, we were there in the summertime in June, and it's brutally hot there in the summertime, like 120-degree days. And we were working out in these tents in the clinic assessing patients, and we had women that were coming in to be seen for their goiters with really large goiters, wearing turtlenecks to cover them up because they were really significant. I was dying in my scrubs, and these women were wearing turtlenecks to cover it up. Body image issues might be something to keep in mind with an older patient that has a goiter as well, especially that teenage age range. Even though this is rare, it's something to keep in mind with that. Don't forget with a goiter, especially for congenital reasons, that airway compromise may be something to keep in mind. Larger goiters may be obvious and you can see them. Smaller ones may only be palpable, where you're palpating that thyroid gland and you can feel it. It could be seen with hypo or hyperfunction. If it's hypofunction, treating with thyroid hormone, so replacing that thyroid hormone. Synthroid is the most common med for that for peds and adults, is going to be the treatment for hypothyroidism, which would help resolve the goiter in many cases. Not if it's dietary iodine related, though. In that case, it may help a little bit, but also getting them exposed to dietary iodine is something that would help too. All right, thyroid Lymphocytic thyroiditis. So this is Hashimoto's disease. This is a chronic autoimmune inflammatory condition. And this is the most common cause of hypothyroidism in our pediatric patients. Peak age of onset is adolescence, so around that like 12 to 14 year age range. It can be seen with kids as young as 6. Most endocrine things happen around puberty. So if you remember multiple of these disorders, thyroid, pancreas with diabetes, adolescence, puberty, it's the most common age that most of these endocrine things present. All of our hormones go out of whack when we go into puberty, right? It's like everything is thrown off at that point. So some of these disorders present at that point when all of those normal hormones in the body are kind of changing. So that's the most common age that we see with this one. And again, we think with most autoimmune things that we see with kids is that it's something like a virus triggers the autoimmune response, where the body starts to destroy that thyroid function. They may or may not have a goiter, may or may not have symptoms. Many kids that have Hashimoto's are euthyroid and they don't have symptoms. If they do have symptoms like delayed growth, delayed school performance, they're sleeping more, delayed puberty, then we would treat, we would give them Synthroid, we would replace that hormone. If they're asymptomatic, if they're euthyroid, it's really just monitoring. Most kids with this disorder will resolve in 1 to 2 years. It's not a like permanent disorder when it presents. Most of the time it's just symptomatic management and watching and waiting for them. Surgery is not indicated for this one because it's a systemic inflammatory condition. So doing surgery on something like the thyroid or taking out the thyroid is not going to help at all for this patient's treatment. So it's not even considered as a treatment option for Hashimoto's. Other side of things, if we have hyperthyroidism, the most common disorder that we see with this one is Graves' disease, another autoimmune disorder related to those TSH receptors in the body, but there's no like specific underlying reason why we know patients get this disorder. There's a slight link with family history with Graves' disease as well. Peak age of incidence for this one is also puberty, around that 12 to 14 years of age, but it can be present at birth and any of those other developmental ages as well. So we just talked about hypothyroid. What are the signs and symptoms of hyperthyroidism? They have too much. Sweating. Exophthalmos, yep, which is the bulging eyes. And that assessment finding for kids, especially when they get it, once it develops, it's irreversible. So preventing that early on is really important because once they have it, it's always there, even if we treat the hyperthyroidism. Tachycardia, they're skinny despite a good appetite. Like they can eat and still have weight loss and not have good growth. Yep, increased metabolism. Yep, they can eat and eat and eat and still not gain weight. Everything's kind of in hyperdrive, right? Hypertension, high blood pressure, high heart rate can be problems that they have. Diarrhea and like increased GI stimulation is also something that can happen. Just think about like everything being in kind of this hyper responsive state in the metabolism of the body. Typically for labs, though, this is not high TSH levels. So this is not usually something coming from the pituitary gland. This is more likely a thyroid base. So they'll have high T3 and T4 levels, but lower TSH levels. Because the pituitary gland is going to try to lower those TSH levels because the T4 is high. It's not stemming from that region. It's stemming from the systemic problem that's happening. So treatment for this one's much harder because kids need that the metabolic rate to be able to function for brain growth, for physical growth. The suppressing it suppresses growth for kids. So it's really hard to find that kind of balance of making sure that they are healthy and growing, but also not having excessive amounts of this, which can cause those other problems. The other thing that we didn't talk about is like anxiety and not uncommon to see some mental health challenges with patients that have a really hard time like settling and controlling like rapid thoughts and those kind of things is more common with hyperthyroidism. Treatment for this one, a couple different options that we have. Antithyroid drugs are more commonly used with adults than we see with peds patients. PTU, the propyluracil, has a black box warning on it for the medication, like literally a black box on it that says it can cause organ failure. It is not a first choice at all for peds patients because it could send them into organ failure, solid organ failure. Methimazole is the more commonly like first line choice. If they had to use an antithyroid drug, methimazole would be your first line choice. We may do a subtotal thyroidectomy or partial thyroidectomy to try to reduce those levels. That can lead to hypofunction. So they may have to have their levels replaced if that's the case. We also sometimes do ablation with radioiodine injections, and that can also slow down the rate of secretion of those hormones, which can still also lead to hypofunction, which may have to be replaced at some point. It's a little bit easier to replace the missing hormone though than it is to lower the high levels of the hormone. So this one's a little bit harder to treat. Thyroid storm is also something that can happen from hyperthyroidism, and it's a sudden release of those hormones where they get like a sudden spike in T3 and T4. It's more unusual in kids to see this, but it can be life-threatening, and it's commonly triggered by stressors in the system. So that can be something like an infection or surgery. So not uncommon in a hospitalized patient that to be kind of the initial problem that they present with hyperthyroidism. Symptoms, really, really excessive in that metabolic rate. Both think excessive irritability and restlessness. Sometimes it's even described as like a psychosis where they're just like really out of it and agitated. Vomiting, diarrhea, high heart rate, hypertension, an elevated body temperature, that hyperthermia is going to be symptoms that we see with this. The treatment for thyroid storm, antithyroid drugs, methimazole would be the first line choice for this one, that M1 that I just talked about, and then propranolol. A refresher on propranolol, those olols, what class of medication is it? It's a beta blocker. It's a beta blocker, so olols are beta blockers. Gotta throw in the farm, Ashley. You guys should know the olols at this point. Everybody knows the olols. Olol, O-L-O-L, beta blockers. What is it going to do for my patient? What symptoms would it treat? It's going to slow down the heart rate. Yep. And then what else? So it's commonly prescribed for things like heart failure, but it's also prescribed for blood pressure. Yep. So hypertension. So it's also prescribed for hypertension. It is bad for asthma. See, you've got the farm on this. Yep, it's bad for asthma. It would not be great for an asthmatic. Sometimes it's like risk to benefits. So two major things is going to be treating those symptoms that our patient's going to be having, the hypertension and the tachycardia. Other thing that the beta blocker can do for the patient that is in thyroid storm is that it helps stop the conversion of T3 to T4. So it decreases the level of those thyroid hormones in the body. We'll actually treat the underlying problem as well as treating the symptoms for the patient. Propranolol is a medicine that you should associate with thyroid storm. Hint, it's a very common HESI question. Started. That one's come up multiple years for HESI. All right, we've got a 13-year-old girl brought into the clinic with emotional lability and restlessness. Other symptoms include gradual weight loss despite a good appetite, warm, moist skin, heat intolerance, and unusually fine hair. These manifestations are most suggestive of which of the following: hypothyroidism, hyperthyroidism, hypoparathyroidism, or hyperparathyroidism. Yes, it is B. It's that hyperthyroidism that we just talked about. Remember, hypo would be opposite of that. All right, we are at a break time, so let's take a break. It's 11:58, so 11:59. Let's just say it's 12. Come back at 12:10, and we'll finish the rest of this. back. We're just going to finish the last few things that we have in here. So adrenal function and the pancreas. So just a couple disorders to talk about. And I only have a couple things in the adrenal function that we're going to discuss here. There are a lot of different hormones, or at least systems related to your adrenal function. We've got those glucocorticoids, which is cortisol. You know, think about things like relation to stress and response to stress, especially with illness with pediatric patients. Mineral corticoids, which are the aldosterone, which think about fluid electrolyte balance for that one. Sex steroids, which are the androgens, the estrogen to the progesterones. So puberty, especially for that one. Also, norepinephrine, those fight or flight responses. Be things that we are seeing with dysfunction with the adrenal gland. And again, the adrenals are also controlled by other systems. So the pituitary gland going wrong or the hypothalamic region going wrong can cause problems with the adrenal system as well. A couple things to discuss in this one, specifically related to like cortisol levels, high and low cortisol levels. If we have acute adrenal cortical insufficiency or adrenal crisis, this is a patient that doesn't have enough cortisol in the system. And this is a problem in terms of response to things like illness and stressors. Can be related to hemorrhaging into the gland. So abdominal trauma can cause this, infections can cause it, tumors can cause it. Are congenital abnormalities that can also cause this, where kids are born without the ability to develop and secrete cortisol, and that's going to be a lifelong problem for them. They have these like chronically low adrenal levels. In those cases, a few kids that I've taken care of with a few of those cases over the years, a lot of times like in the EPIC chart system at the top, you can put flags in the chart and it would say, you know, at the top, warning, patient has adrenal insufficiency, has to have cortisol injections at first sign of illness. So anytime they get sick with a cold or a fever, they have to have that cortisol administered externally because their body is not going to be able to respond and make it. And the signs and symptoms for this one, kind of just general like big clinical symptoms for this one, as well as lab levels that would show low cortisol levels, are like flu-like symptoms, as well as signs of shock-like, and more like hypovolemic shock symptoms is kind of what we see with this one. Their body's just not able to respond to stressors, so they're going to have problems just compensating for those kinds of things. So fever, nausea, vomiting, just vague irritability and headache and lethargy, confusion are things that we see with patients that have adrenal insufficiency. Our main treatment for this is treating with replacing the cortisol, and that fastest way would be IV hydrocortisone, getting it in that fastest way, IV hydrocortisone. Also think about things like IV fluids with dextrose, and that response with like that glucose is needed for this patient to help with their symptoms. Cushingoid syndrome is too much cortisol, and this could be an underlying issue, underlying congenital issue. This could be in kids, this could be a tumor in that region that's causing that excessive secretion, and that's the most common cause in young kids of Cushing syndrome. We also see this because of steroid administration secondary to disease processes. So one of the ones that we've talked about this quarter was cancer, and patients that are getting cancer treatment are often put on steroids. And that's something that can cause the Cushingoid appearance and syndrome to happen. It's temporary for those patients. It's going to be something that once we stop those hormones administrating, those external hormones, their symptoms will get better. So that Cushingoid appearance will get better for those patients. And just like a quick note about that, abruptly stopping steroid administration can cause acute adrenal insufficiency. So that low level of adrenal insufficiency. Basically the adrenal glands, when they're getting external steroids, IV or oral, the adrenal glands get lazy and they stop producing their own steroids because that external steroid that's being administered. So when we stop those, adrenals have to kind of wake back up and start producing those hormones again, the cortisol again. It takes them a little while. That's the reason why we're doing those steroid tapers when patients are on high dose steroids, especially for longer term. You have to do that taper so those adrenal glands kind of like wake back up and remember what they're supposed to do. Making sure that patients know that they can't just like stop cold turkey with a steroid. They have to taper them off, especially if they've been on them for a while. If it's related to a tumor, then we may have to take the tumor out. That can also lead to adrenal insufficiency or low levels. And just a refresher on that cushingoid appearance for kids that have those high levels of cortisol. This is the moon face, the striae, the weight gain. They get poor wound healing and ecchymosis. And those are all things that will reverse after we stop that steroid administration. The exception are things like the stretch marks, the striae. Those are skin changes that are usually permanent. Body image issues would also be something to keep in mind with this patient that's going through this. And then a congenital abnormality in this system is congenital adrenal hyperplasia. This is the most common cause of ambiguous genitals that I talked about a couple weeks ago in the GU system. But this causes excessive androgens, which are those masculizing hormones. So in a baby that has this in utero, in development, especially females, little girls, they're getting too much androgens, those masculizing hormones, and so their genitals, especially externally, will look more like male genitals. Genetically, chromosomally, they're still a female. It's an autosomal recessive disorder, and we can test for this at birth. So this is one of those newborn genetic screens that we do on that little Guthrie heel stick test. We catch this early, we can manage it, and basically the treatment for this one is administering glucocorticoids, which will suppress those androgens. And then remember with the ambiguous genitals, we talked about that as being more like the psychosocial impact, that we would also maybe talk about surgery and corrective management for the ambiguous genitals. My dog came in to visit. All right, last section, pancreas. Our pancreas. Diabetes is the main thing we're talking about here with pancreatic hormone function. So remember, you have those alpha cells, which are responsible for glucagon. You have the beta cells, which are responsible for insulin. And with type 1 and type 2 diabetes, it's those beta cells that are going all wonky for us. And this is the most common endocrine disorder of childhood. This is the most common one, like across the board, that you're going to see with patients with diabetes mellitus. Also, remember with your patients with cystic fibrosis, remember they can get pancreas failure and they can get diabetes mellitus secondary to that as well. That would be something to kind of make that connection between those two disorders. The peak age of onset for this one is also adolescence. So those 12 to 14 years is kind of most common, but anytime between that 12 and to 15, but any age, patients get diagnosed with diabetes, whether it's type 1 or type 2. We used to call type 1 childhood onset diabetes and type 2 was adult onset diabetes. That's not the case anymore, mainly because type 2 diabetes is seen pretty consistently with our pediatric patients nowadays, mostly still with adolescents. And the biggest contributing factor with that one is obesity. Weight gain is the biggest thing that we see in combination with that. And patients being higher risk for developing type 2 diabetes in childhood. Otherwise, type 1 diabetes, something that we typically say, there's a positive family history somewhere in the family, but that's not always the case. Sometimes kids get diagnosed with it with no positive family history. Some parents that have it never have a child with type 1 diabetes. So it's one that's like, why does this happen? Newer research over really the last just couple of years of researching diabetes, they have found a lot more strong evidence that points to the fact that it's an autoimmune disorder. So what really they think is happening with those beta cells being destroyed is that there's that genetic predisposition. They have the positive family history. Mom or dad had diabetes, aunt and uncle, some positive family history predisposes them to it, and then something triggers that system, that autoimmune system in place that destroys those beta cells, and that leads to type 1 diabetes. And we think that that's a viral infection. It causes that inflammatory response, causes this autoimmune response to happen in the body, kind of like when we were talking about cancer, similar genetic predisposition to it, but what makes one person get it and not somebody else. So the assessment findings for this, Same thing with adult onset with type 2 diabetes, polydipsia, polyphagia, polyuria, enuresis, that bedwetting, wetting their pants, maybe one of those early symptoms, especially for younger kids. Irritability, fatigue, weight loss, failure to thrive, the growth failure. It's something that we see with kids with this, as well as things like nausea and vomiting. And then lethargy and decreased level of consciousness can happen if they have very high levels, especially with a first-time diagnosis, and they may be in something like DKA. I don't go into diabetic ketoacidosis in too much detail. There are some fairly significant differences with how we treat DKA with an infant versus an adolescent. You know, their kidneys are not functioning the same way. Their fluid and electrolyte balance is very different with infants versus adolescents. So this is one that medically there is kind of a big difference between treatment for that urgent need with DKA. We don't go into detail of that. You don't need to know that as a student, at least for peds, to get through peds class. If you go into peds, it's something you will deal with. Basically, when a patient can't metabolize that glucose, they metabolize their fat, and that releases ketones, which are acidic, and that leads to DKA. Classic signs and symptoms: Kussmaul's respirations, where they have rapid, deep respirations. They started as like rapid, shallow, and then turns to this like rapid, deep breathing pattern with a fruity, kind of sweet smelling breath. I think it smells like powdered sugar, like that you put on, you know, food. I've had it also described to me as like Fruity Pebbles, like the cereal, but it's this kind of like sickeningly sweet kind of smell to it is what their breath will smell like. Level of consciousness will decrease as DKA gets worse. So they may be lethargic, they may be confused, they may be in a coma. Vital signs can be altered. Their blood sugars are going to be high. It doesn't necessarily mean the higher the blood sugar doesn't necessarily mean how bad the DKA is. Really looking at your blood gas and looking at your pH will tell you how acidic your patient is or not for that, as well as electrolyte imbalances for your patient. So those are all things that need to be assessed and monitored and measured well for your patient that's in DKA. Bringing the blood sugar down slowly, too rapid can cause things like cerebral edema and further complications. So slow moving of the blood sugar down. Peds patients, kind of a difference with Peds patients. It's a challenge with working with Peds patients with DKA and managing type 1 diabetes. Remember, with Peds patients, and especially adolescents, they don't like being told what to do. They don't like, you know, having to like do things because they have to. Really want to express that independence. So being diagnosed with something like diabetes in those adolescent years can be very challenging for kids. They also sometimes have that body image issue. That's something that's very common at that age. One of the things that we see commonly with DKA and type 1 diabetes is more so with girls. Sometimes we get guys that have this, is that they will try to manage their weight, keeping their blood sugars high, because they burn fat when their blood sugars are high, and that keeps them skinny. They have weight loss and it keeps them skinny. So I had multiple patients that would just like in and out, would end up in DKA in the ICU multiple times over those adolescent years because they were trying to like ride those blood sugars and keep them a little bit higher, keep their weight down. The challenge with diabetes, so you remember from med-surg, are those longer term changes that can happen, those microvascular and macrovascular changes, neuropathies, nephropathies, retinopathies, are changes that happen because of those high blood sugar levels. Kids, teenagers, while they can think future tense, aren't usually thinking about, you know, something that may impact them later down the road. Like, oh, you can have a heart attack when you get to be older. Oh, this could lead to blindness as you get older. It's not something that they're usually like really taking into consideration. Unfortunately, I've seen teenagers that have gone blind because of poorly managed diabetes, and especially into those 20-year-old age ranges where they're starting to have complications already, because they happen in the first 25 to 30 years of being diagnosed. And for early onset patients, for the 2-year-old that got diagnosed, that's in their 20s, early 30s that these complications can start to pop up. Diabetic retinopathy is the leading cause of blindness worldwide. type 1 and type 2. Leading cause of blindness worldwide is secondary to diabetes. Helping adolescents and helping younger pediatric patients understand those risk factors, especially as they're moving into adulthood, is something that's a challenge with pediatric management. With younger kids, it's the parents, right? The parents have to be more vigilant about this and helping their kids manage their diabetes. So managing it, we do those blood sugar checks with meals and at bedtime. That's kind of the standard with that. Insulin therapy is going to vary depending on the patient's individual needs for monitoring and measuring their glucose and keeping them under control. Generally, our goal is 126. And we use regular insulin, we use Novolog, we use like any of the other ones that you use with adult patients. They're just going to be weight-based and specific to the patient's needs. Lab measurements, A1C is something we do on a regular basis to check for long-term control of those blood sugars. What should your A1C be less than, or kind of equivalent to? What are we looking for that A1C? Generally, yeah, 5.7. Generally, if you can remember 6 is a good number to remember for this one. For healthy patients that don't have diabetes, less than 5 would be the measurement we're looking at, but 6 is generally a good rule of thumb for this one. And then illness management is also something that is important to talk about with PEDS patients. Remember, PEDS patients are going to get sicker more frequently than adults. They get more colds, they get more illnesses than our adult patients will. So that illness management is absolutely something that is a priority kind of education piece, especially for parents. And for us in acute care, it could be something like the kid that comes in with like an RSV, like a respiratory illness, and they have they're an underlying diabetic. Their blood sugars are going to be higher. Those blood sugars are going to be higher, are going to impact all of their other systems. And if they're already acidic from diabetes, that's going to make it really hard for us to manage their respiratory system. So acute illness management needs to look at things like measuring ketones. Usually we don't dip the urines if they're healthy, but while they're sick, doing regular urine dipsticks to look to see if they're spilling ketones. And usually this also means that their blood sugars are going to be higher, that cortisol goes up, glucose goes up in response to that illness. And so they may need more insulin and better management or tighter control of the management while they're sick. And with kids, that happens more frequently than it does with adults. Also recognizing their high and low signs and symptoms of hypo and hyperglycemia is something that's a challenge for little kids. As we've talked about with other disorders, right? The toddler is not good at recognizing their symptoms of asthma. They're not good at recognizing their symptoms of diabetes. They need teachers and adults and coaches and everybody else that's around them to be very vigilant and know what those signs and symptoms are. The teacher needs to know, because the kid that's falling asleep in class, it may be because they had a really late night and they didn't sleep last night, or it's because their blood sugar is really high and that's why they're falling asleep. So everybody, all the adults that are taking care of this kid need to be aware of those high and lows. And we have a lot of these different like cartoon pictures that we use with kids for that like verbal and physical and like visual teaching for their high and low signs. I have a little jingle that I use for preschoolers because they can memorize things at that age. They're starting to learn language really well. They're starting to write stuff down. So the little short jingle that I have that's like a couple quick things to remember with high and low is hot and dry, sugar high. So that dry mouth, extreme thirst. Cold and clammy, they're like sweaty and kind of dizzy and trembly. Cold and clammy, need some candy. And not like little kids at preschool age ranges like that. It rhymes, it's a rhyme that they can remember and helps them kind of understand some basic signs and symptoms of their high and low levels. And then they still need the adults around them to be vigilant. Record keeping and home monitoring is important, especially for long-term management for this. This is so much easier now than it used to be. It used to be paper records where we had like little books that they would have to write it in, but it's all monitored digitally, at least in the United States now. All of our like glucose monitors are synced to the apps on the phone, keep a track of them. And some of them even sync directly to the medical records so that they can be sent right to the doctor and the doctor can see all of those medical records, which is great. Now, things that teenagers do, get around this. I have had teenagers that, you know, come in and DKA, and the parents are like, I don't know what's wrong. You know, their blood sugars have been great this whole time. How did this happen so suddenly? Yeah, they will do things where they will check their friend's finger while they're out at lunch, because they all went out to go get burgers and fries, and their friend doesn't have diabetes, so their friend's blood sugar is okay. They'll check their friend's blood sugar and put that in the monitor instead of checking their own. They already know they're going to be high. Those kinds of things teens will do. Parents still need to be very involved in keeping an eye on the blood sugars, even when they're adolescents and they're a little bit more independent and checking their own blood sugars. Now with younger kids, it's the parents that are going to be doing the finger stick. So there's a range with what that looks like. Other difference now that we have insulin pumps that are continuous insulin pumps that sync to continuous glucose monitors. And they work basically like our pancreas does. So they recognize when we have glucose spikes, and it will administer insulin in response to that. It's not as good of a system as a real pancreas, but it works much more effectively than what we used to have to do, because it's a more like time sensitive kind of up and down that we see. I have a video that I'm going to play of a 5-year-old who's putting on her insulin pump. It's an Omnipod, one of the brands. And I really like this video, kind of wrapping up developmental stage, thinking about what a 5-year-old can do, like being involved in their care, the things that they can participate in. And she's teaching you how to do her Omnipod. So we're going to watch this video. And we have a couple more things to finish up after that, and then we'll be done.
If you're ready to start living life on your terms without letting blood sugars get in the way, then this is the most important video you're going to watch all day. Well, I'm about to show you how I actually help.
Hello, my name is Olivia. I have type 1 diabetes. I will be showing you how to put on my pump Omnipod.
All right, so this is our Omnipod pump, and you're going to know.
While the Biden administration is doing everything possible to counter Russia's invasion of Ukraine, while
pump, and you're going to notice something. First of all, we've already taken the lid off it, and we have little stickers. So we made little stickers that we put on it. You can put anything you want. It's an Easter coming up, so we made a little Easter sticker to put on it. All right, so hold on. So the next thing we need to do is we're going to take this out. We're going to take this stuff out, right? Now what do? You go ahead and put it on.
We take it. I have this, and it is the needle.
Okay, good. Now hold on, be careful. Now what are we going to do? Take the lid off. All right, now I'm going to clean this. All right, now hold on. Let's get a little bit of air in it. First thing we're going to do is we're going to get 80 units of insulin minimum to put in here, because that's all that Olivia needs, right?
Mm-hmm.
So we're going to put it in here, and we're going to pull it out. Do you want to pull this plunger down slowly?
Yeah.
Keep going, keep going, keep going, right about there. Okay, now these are your bubbles. Give it a little flick. All right, so we got it past the minimum. So what we'll do now is we'll take this off. All right, now we're going to turn the pump on. And the first thing the pump says, you with me?
Mm-hmm.
It says, no active pod. Would you like to activate it now? Yes, we would. All right?
Mm-hmm.
And it says, put the insulin in and wait for the beep. So go ahead and put the insulin in.
Yeah, we have to have
There's
a
little
lot
hole here.
of light for this. You push it in,
Yeah, I'll hold it for you and you can push the insulin in.
and then you have to keep it very straight. And then push the insulin.
All the way down. All
And
right.
when you hear that, did you hear that little beep? And that beep means that it's ready and all the insulin in it.
Okay. So what's happened is we have the insulin in the machine now, and it activated a beep. So the next step is, it says click next. So now it says that it's going to prime it. Prime it means it's going to get all the air out of the pump, right?
Yeah.
So what's it doing? Is it clicking?
Click.
Gotta wait.
Alright. I'll tell you guys when it's done.
In the meantime, I'm going to put the lid back on this. Almost done?
Almost done.
Okay, you're ready. Okay, so it just beeped, and now it says to remove the plastic cover. So go ahead and snap that off. Show them how to do it.
We take it off. You have to go really hard.
Okay, so this is just the protective plate.
We just tap it on our clothes.
There you go. To get a little bit extra, get the ins and ooze in there, right? Okay, good. Next step. All right.
Next.
All right. Now it says take the adhesive off. So take the sticky stuff off. There we go.
Sometimes I just touch it so I can get it off easier.
Okay. Now let me hold it for you. All right. Now the next step is
To put it on me.
that we have to put it on her. Now Olivia's chosen today that she wants to put it on her tummy. So what side do you want to put it on?
You need money won't get to that. Right to if you haven't let it go. You need money won't.
You want it on this side? Okay, so we're going to pull this down just a little. You want on that side? All right, lay down for me. Okay, perfect. So let's go ahead and wipe it off. Does that tickle?
Yep.
All right. So we're going to let it dry. It's a little what?
Little cold.
A little cold. Okay, we ready? All right, so basically you just stick it on. So we're going to line it up to where we think it should be. If it's on her tummy, it should be this way. If it's on her arms, it should be this way. But we're going to put it on her tummy in a good spot where we think it looks good. How's this look? Right here?
Oh, or down.
Down more like that?
Right there.
All right. So there we go. We're going to stick it on, and we're going to rub down all the edges all the way around. I find that the more you rub it around the edges, the more it sticks.
And the better it sticks, the better it's on.
That's right. All right. So we've got it pushed down pretty good now. And the next step is, do you want to sit up, or are you going to lay down when we do it? It's your call.
I don't know, but first I have to be
Okay.
here.
So now it says press start. So all that's going to happen is I'm going to let Olivia press start whenever she's ready. And what it's going to do is it's going to count down, and it's going to put the cannula inside her. All right. So I'm going to pinch it for her just a little. And anytime you're ready, honey, tell us when you did it.
Ready.
All right. So it's ticking away. Oh, did you press? Oh, a little closer. Watch out, babe. There we go. It's ticking away. There we go. Did it go? All right. It's good. Did it hurt?
It's just like a little somebody pinching you.
Just a little pinch, right? So if anybody's out watching, did it really hurt?
Nope.
All right.
And
So the next, hold on. The next,
the little window.
yeah. So the next step is you're supposed to look through that window, right? And we're supposed to make sure that it's in there, okay? And I can see that it's in there. Great. So we're going to click yes. It's inserted. And we are,
Ready.
we're done. Pumps on. Thank you for watching. Bye.
Bye. I hope you enjoyed it.
Forget expensive solar panels. Get Tesla's.
Okay, is she not the cutest? I love her like explanation. She knows what she's doing. So that's a 5-year-old. So that's really like, especially for those of you that don't have a lot of experience working with kids, thinking about developmental stages in theory is hard to do sometimes. Like, what can a 5-year-old do? That is a 5-year-old being able to like be engaged. They still need support. They still need the parent there. They can participate in their cares. And man, those pumps now are just so much easier than they used to be. There used to be like all these tubes, and you had to wear like, fanny pack, and they had to have just a lot more management. Also self-cannulating. So the little needle that's in there like automatically inserts the little cannula, and then the needle retracts, and they just have the little plastic cannula in the skin. Just so much easier to use nowadays. So those are Omnipod pumps, and if they're using the continuous Omnipod glucose monitor, that's usually put into a different location, usually like the back of the arm, and that'll continuously monitor their insulin, and they talk to each other, and they can go up and down depending on what the patient's needs are. So hygiene also is another thing to keep in mind, especially with teenagers. That's one of the biggest things that is a challenge with teenagers, like those hormones when they get smelly and stinky, and they need to be extra careful with their hygiene. Family support is also something to consider. I'm not going to play that second video today, but the video goes through like mom talking about her adjustment, and she's got a kid who was diagnosed as a toddler but is a school age child now, and just things like not being able to run to the ice cream truck when the ice cream truck goes by in the summertime because their blood sugars are a little bit high, and having to change the whole family's meal plan because they have to keep, you know, better control over that patient's nutrition. Or their child's nutrition, and planning for vacations, just extra steps to plan for. Acute care management also, just for us, especially if kids are sick, and making sure that we're monitoring those blood sugars closely while they're sick in the hospital, because they're going to be higher and sometimes it's harder to keep control of. Nutrition is also something that we want to make sure that we're addressing. The concept of normalizing childhood is something that I've talked about several times with disorders and disease processes with our peds patients. We want them to have what the family considers a normal childhood, and just it's things like going to a birthday party and having cake and ice cream at a birthday party with their friends. Being able to do that is important, but portion control and making sure their blood sugars are under control before they go in is important, right? Like, can't go to the birthday party with a blood sugar of 300 and still eat cake and ice cream. But we want them to have as much freedom and flexibility with that as possible. And the newer insulin pumps have been a big help with that over the years. And those are pretty new, maybe 5-ish years, I want to say we've been using those Omnipods in peds, maybe a little bit longer than that. Then exercise is also really important to make sure that we're getting in for peds patients. It's one thing that we know has been able to help decrease complications and risk factors for pediatric and adult patients. You know, those macrovascular, microvascular changes is keeping up and being active, and it impacts their blood sugars pretty significantly. So we want to make sure that we're helping them adjust to that. So let's say we've got a school age kid that's playing soccer for the first time, and she's going to be playing soccer and she's got diabetes. Well, her blood sugars are going to go down if she's exercising and she's using you know, her glucose, and she's got insulin on board. So she has to make sure she's got insulin on board to use that glucose, but also making sure she doesn't become hypoglycemic during that exercise activity. So especially when kids are starting new activities like that, we have them monitor their blood sugar before the soccer practice and after their soccer practice, so they can see how much does an hour of soccer practice drop their blood sugar. So that they know, okay, I need to eat a snack. I need like a 30-gram carb snack before I go exercise. Help them maintain those kind of stable blood sugars. And that's hard to do sometimes, but helping them kind of figure that out. Also going back to things like younger kids that can't recognize their symptoms, the coach, the teacher, the parent needs to be looking out for those symptoms. You know, the kid going out and playing soccer, that their blood sugars are starting to drop. They may be starting to stumble more. They may be tripping over the ball more. They may not be able to cognitively recognize that it's because of their blood sugars. They may need the parent or the coach on the sideline that's like, whoa, wait a minute, let's pull you off. Let's check your blood sugar and see what's going on. Managing that stuff is different now than it used to be. When I first started nursing, the first job that I had on a peds unit, we would have new onset diabetics that would get admitted, and they would spend a whole week with us. And you would have your primary patient that you ate meals with them, you like sat down with them, you checked their blood sugar, you counted carbs with them, and you did this like whole week long teaching session with them. And that's not the case anymore. It doesn't happen that way. Honestly, I've had kids in the ER that are not in DKA. They get diagnosed with type 1 diabetes and they'll get sent home from the emergency room. They don't get admitted at all sometimes. And then they'll follow up with a place like the Barbara Davis Center and get outpatient education. So it's just different. Like the inpatient, we used to take them on walks and we would check their blood sugar before and afterwards. Management of it looks a little bit different than it used to, but it has gotten better for kids, especially with the new pumps. All right. last little slide here is a little case study. So just kind of wrapping this up. So Shelly is a 14-year-old with a 3-year history of type 1 diabetes, has been admitted to the pediatric ICU for treatment of her DKA, or diabetic ketoacidosis. This is her 5th hospital admission for DKA in the past year. Shelly's parents are divorced and she has 4 younger siblings, none of whom have diabetes. Shelly's mother has maintained 2 jobs for the past 5 years and frequently leaves Shelly in charge of the household. In anticipation of her discharge, you are planning a patient education program for Shelly and her mother. What important issues regarding Shelly's unstable diabetes management might you consider to plan the education? Think about your initial assessment. What are the concerns related to Shelly's recurrent DKA episodes and family stressors? So separated parents, divorce, yep, it's an added stressor. Mom working 2 jobs, yep. And she's probably doing that to make ends meet, right? For 5 kids. Lack of consistency is absolutely a possibility. She's 14. She's not able to really be consistent with her own skills yet. Meal management with busy parent. Absolutely, right? Can a 14-year-old meal plan effectively? Maybe. Consistently, long-term, it's a struggle. Lack of knowledge, yeah. The meal prep itself, is she really aware of what meals that she needs to eat on a consistent basis? Frequent hospital visits are super overwhelming, especially for a teenager. Remember that peer engagement. If they're in the hospital, are they being involved in peers? Are they, you know, do they have friends outside, especially if she's being responsible for taking care of her siblings a lot of the time? Is she able to be a teenager? The only one with diabetes, right? Mom doesn't have it, kids don't have it, the other siblings don't have it. So just having somebody to relate to and also keep track of. He's being an adult while mom is gone. Yep, absolutely, right? That is not something that we want to expect of most teenagers. Now, this is not uncommon for us to see this. This is something that does happen a lot, especially in families that have challenges with their socioeconomic status, and a mom that's working 2 jobs for 5 years to make ends meet. That socioeconomic status is also something to keep in mind. Meal planning with low income is very challenging. Most like food banks and foods that are readily available for families that are living on low income are usually high carb, high starch, high sugar. Not good for a diabetic at all. So just financially being able to supply meals and being able to do that. An example from my personal experience, I grew up impoverished and we had family 5. So I had 2 siblings. So there's 3 of us, or 5 of us. And a frequent meal that I would make as a teenager for us, my younger siblings I would cook for, was a box of Hamburger Helper with an extra box of spaghetti noodles thrown in there to make it feed 5 people. Super high carb, super high sugar. It was something that we could afford. So it's something that you know, families that struggle with finances really commonly see a challenge with, and diabetes, it makes it harder, so much harder. Yeah, healthy food is really expensive. All right, so we've got all of these stressors in here, right? Thinking about your nursing action, what education would you give? How could you help this family cope with all of these things that are going on? Imagine having to discharge this family. What would you do? Okay, educate on resources. And what would those resources maybe look like? Do you have examples of what that might be? Printed educational material would be appropriate for an adolescent and an adult. Yep. Food banks, yep, and making sure that we try to connect them with ones that can give healthier food choices. There are some out there that are specifically useful for patients that have underlying issues like heart failure or kidney issues, those kinds of things. Rare, but it does exist. Insulin is expensive, so possibility with that as well. So a social worker would be a really good resource to help them connect to. The social workers are really good at helping connect with those other resources like food banks and financial resources. Yes, the nutritionist. Don't forget about the nutritionist to help with meal planning and recipes. Yep, absolutely. So easier prep recipes for a 14-year-old that's meal prepping for 6 people because she's got 4 siblings and her mom, right? What if mom's still not able to be there during the week? Like she has to maintain these 2 jobs to be able to make ends meet, you know, pay the house, pay for the food, those kinds of things. How can we work around that? These are those real life examples that we have to deal with as nurses. This is like the textbook stuff this is the non-textbook stuff that we have to deal with as nurses, right? Yeah, get dad involved. And I didn't specifically put anything about dad in the picture. He may or may not be involved in the picture. So if dad is involved in the picture, yeah, maybe dad can help a little bit more, but they're divorced, so they may not see each other, right? School nurse could be a good thought. Yep. There's not always a school nurse available. Many schools, public schools nowadays don't have school nurses on site, but maybe a good resource, especially for education and just like re-supporting that education that's being given outside the household. So I'll give you one example that may be helpful for like meal prep and planning for the week. If mom especially isn't going to be there, you know, multiple days during the week, is that maybe on Sundays, that's the day she's home, or Mondays, that's the day she's home, whatever day she's home, they do some meal prep together. That mom sits down and says, okay, these are the meals that we're going to have this week. This is how much you should be having, you know, this is an appropriate for you, and like help with some of those more challenging aspects of it. Maybe like pop some of the food together so Shelly doesn't have to do all of the meal prep. There's like things that she can just pull out, or there's freezer full of stew or other things that have been pre-made, you know, big crock pot meals and those kind of things that can really help that management and still allow her to be a teenager. She's got school to worry about herself. She's got her peers that she really needs time with to be able to help with her development. And that goes along with diabetes too, right? She getting engaged with other kids, other teenagers that are dealing with diabetes is also really helpful for that support. Psychotherapy may be something to consider as well. Those are real life challenges that we have to work with. And helping her stay out of DKA may help her long term. And helping mom understand that she's causing some long-term issues for her child. It could be avoided with a little bit of prep and a little bit of advanced timing. Okay, so hard question to answer, right? Those are things that you can't fix, and especially related to patients that have lower socioeconomic status, that creates a lot of other barriers. It's easy to say, well, like, oh, you have to manage your DKA better, but how when there's so many other barriers in place? Alrighty, guys, that is it. Very nice job. Thank you for a good quarter. I enjoyed teaching you this term. Please have a good break. Let me know if you need anything.
Thanks for everything.